Good afternoon, colleagues and friends. I'd like to say a very big thank you to the organizers of this conference for giving me an opportunity to talk to you about some of the problems faced by our doctors in their clinical practice. My title that you see on the screen now will vary slightly from what you've got on your program, but I decided in discussion with the organizers to move away from focusing just purely on safety, but to look at some of the issues related to the occupational exposures and how these give rise to occupational diseases in clinical practice. So on the basis of this, the title of my talk is essentially how do we protect doctors against the adverse health outcomes that they experience as a result of their occupational exposures in their clinical practice. But before we start talking about doctors specifically, let's take a step back. In the world prior to the SARS-CoV-2 virus, we know that already over 2 million workers die every year from an occupational disease, 300,000 from an occupational injury. So even though we as doctors feel as if we're immune to the problems of workplace exposures, we may be part of this very, very concerning statistic. It costs $3 trillion to the global economy because of occupational diseases and injuries. But yet, if you think about the amount of resources we spend addressing this problem, it becomes quite concerning. So the International Labour Organization provides this and emphasizes this statistic and basically demands of us to look at how we address the problem. But we as doctors, while we're on the front line trying to protect the health of others, we also need to concern ourselves with how we protect our own health. This came into very sharp focus, the health of doctors during the pandemic. We know that although doctors were at increased risk for acquiring the infection, it became increasingly concerning that doctors may have been at increased risk of the most serious outcomes of the infection, such as that of hospitalization and death. And so some of the studies that have begun to emerge have clearly started to show that health professionals generally, and doctors in particular, may be at particular risk for these adverse outcomes. This UK study here of over 120,000 biobank cohort participants showed this quite clearly. When they looked at healthcare workers generally, there was over a 7-fold increase of risk for hospitalization in these workers when compared to non-essential workers. However, when you looked at healthcare professionals within the sample of healthcare workers generally, this increased to almost 9-fold. So doctors and nurses were more than 9 times more likely to have a more severe outcome of COVID-19. And this, if you look at model 6, it adjusts for all the usual vulnerable factors. So notwithstanding the vulnerability criteria, doctors and nurses were at greater risk for this. We saw similar sorts of statistics in the South African data. Although our South African data has not yet been well analyzed, particularly for healthcare professionals, colleagues looked at the DATCOV data, which is hospitalization data for people with COVID-19. And what they found that approximately up to the end of the second wave, approximately 4% of those that were hospitalized were healthcare workers. And this shows as well that in the 2 waves that we experienced up to the early part of this year, the numbers of doctors or healthcare professionals in the first wave constituted approximately 5% of hospital admissions. This had come down by the second wave to approximately 2.5%. The reasons for why this may have come down could be initially that healthcare workers will less experience in the way they approach the infection, less careful about their protective gear, as the epidemic unfolded, their ability to protect themselves improved. However, it's not clear as to why healthcare professionals have an increased risk of the more serious outcomes. But we know that COVID-19 is not just an infection. And particularly for doctors, long COVID is of a serious concern. More so because this is so poorly documented among healthcare workers generally, but particularly amongst doctors. And apart from long COVID, we know that the infection and its consequences have given rise to a whole range of mental health outcomes. And these, you know more about these than I do, being on the front line and experience these on a daily basis. But working as a doctor is not just about being exposed to infections. And although the SARS-CoV-2 virus brought into sharp focus the consequences of workplace exposures, we still tend to be more focused on infection. But this does provide us with an opportunity to try to understand better how workplace exposures are likely to impact on the health of doctors. What we need to do is to use the principles of occupational health and find the tools that will help us protect ourselves, not just from biohazards such as the SARS-CoV-2 virus, but also other exposures in the workplace. So, using occupational health principles, the first thing that we need to do is to understand what are the hazards that we find in our workplace. Bearing in mind that not every hazard is a risk. For example, a beaker of sulfuric acid in a closed cupboard is a hazard, but does not pose a risk until that chemical is removed from that particular cupboard. So what we need to do is, having identified the hazards, we then need to understand what is the level of risk that is posed by these hazards in our specific workplaces. Recognizing that doctors work in different working environments, in different contexts, and the risks even among doctors will vary all the time. So it's important that these sorts of assessments of risk are individualized to the different workplaces. Given that we've identified risks in specific places, we then need to focus on how do we control these risks, how do we control the hazard to ensure that it does not become a risk. In other words, keep that bottle of sulfuric acid in the cupboard for as long as we can. Because we know that if we don't appropriately control the hazard, it is going to result in health outcomes. And so that's what we want to try to understand today. So when we in occupational health and in occupational medicine in particular try to understand the hazards that we face in different workplaces, we try to categorize them into one of 6 different categories. I'm not going to go through all of these because some of them will be pretty obvious to all of you, but to pick on a few to highlight some of these as examples. First one, obviously in a healthcare setting, is that of the biological hazards. And we know this all the time. But there are different types of biological hazards. We have those that are spread through the air. We have those that are spread through bloodborne, through blood contact or of any other biological sample contact, as well as the direct contact agents. Understanding these 3 different categories, understanding the type of biological agent and how it is spread, gives us a better opportunity to understand how they pose a risk and how we control it. Similarly, if we look at physical hazards, we know that doctors in nuclear medicine and our radiologists well understand the risks of radiation and take steps to protect themselves. But you may ask, in the healthcare setting, where do we have noise? And how can noise present with such at a sufficient level that it will become a cause adverse health outcomes. I'll show you some studies that have been done on this in a short while. And then for those workers working in laboratories, particularly, temperature extremes, working in extremely cold or extremely hot environments becomes an issue. Clearly, the most important and probably the one that we as doctors concern ourselves least is that of chemical hazards. And as you can see in the list that I've got there, this is only a partial category of types of chemicals that we find in healthcare settings, and doctors are exposed to this at different levels depending on the types of work that they do. We do know that our anesthetic colleagues are probably the most aware when it comes to health and safety because of the types of agents that they're exposed to and their ability to look for ways in which they can better control these. But some of the other agents that we're exposed to are less well controlled and therefore pose a risk to the workers, to the doctors that are exposed to these. So those are the hazards that we find. But the next question is, yes, we know that these are hazards, but, you know, I don't know of any stories of workers becoming sick or doctors becoming sick because of these exposures. The question then we have to ask ourselves, given there's hazards that we face in our workplace, do they pose a risk? In order for a hazard that we find in our workplace to pose a risk, there's got to be exposure to that particular hazard. We've got to understand the mechanism or the pathway in which that hazard results in exposure. If you have a hazard, if you're exposed to a hazard, there's a potential for risk. That risk will vary depending on how you're exposed to it, and we'll explore that in a short while. But also, very importantly, not everybody who is exposed to a hazard is likely to have a health outcome. So there may be individuals who are particularly vulnerable to that exposure. And we know this with a very common example in the healthcare setting, the use of latex gloves. At least now we've mostly replaced the allergenic gloves with hypoallergenic latex gloves. But we do know that not everybody who used latex gloves developed dermatitis. Okay. So certainly there are certain individuals exposed to this particular hazard who are at greater risk for developing this health outcome. So in order for us to understand this, we've got to conduct a risk assessment. And we've got to conduct, as you can see, because hazards and exposures will vary across different clinical practices, we've got to conduct these in the various places where we do have these exposures. What we do when we conduct a risk assessment, we try to understand the likelihood of exposure, and we then also determine the severity or the consequence of that particular exposure. And by trying to understand these two different criteria, we create a risk matrix as shown on the slide here. And if the exposure is very likely and the consequence is extremely serious, then one will rate this as an intolerable risk. As you can see in the bottom end of your slide, showing you this red block. And based on that, we make determinations about how we control the hazard, how much of resources do we need to invest in controlling a particular hazard. So if the hazard presents with an intolerable risk, then obviously we have to throw vast amount of resources to ensure that we do control it and we do prevent people from becoming ill. And if it's less likely, then and the risk is small, we adopt a different approach to that control. Right. So what we've seen so far is that we've got a hazard to which we are exposed, and if we're exposed to it sufficiently, it could pose a risk. Now, the risk that we're most concerned with in this talk anyway is occupational diseases. There have been lots of studies which have shown fairly substantive health outcomes amongst doctors. And these are for the more common conditions which all of you may have experienced from time to time and are fairly familiar with. Psychosocial disorders, like I've described under COVID-19, musculoskeletal disorders, your sharps injuries, and violence in the workplace, particularly in your trauma units, etc. And then, of course, infectious diseases. However, for other occupational diseases, there's less consistent data and fewer studies have been conducted among doctors. And these are for your allergic diseases, your work-related asthma, cancers, and reproductive outcomes. There's obviously a much longer list, but these are some of the ones that we need to be concerned about. And the reason for this is because we have so few studies being conducted amongst doctors as a group. You have lots of studies that have been conducted amongst healthcare workers generally, but these tend not to focus on doctors. We'll come to discussing the reasons why that may be the case. But let's look at some of the examples of exposures in a clinical practice that may result in adverse health outcomes. As I mentioned, I think our anesthetic colleagues are probably way ahead of most of us in terms of protecting their health from adverse outcomes. But this is just one study, albeit an old study, but it shows you the risk that doctors face. So here we have female workers in hospitals exposed to anesthetic gases. And these females had almost a twofold increase in risk for spontaneous abortion. But it's not just the female worker that was affected. If male workers were exposed to these anesthetic gases, they had their spouses had almost a 2.3-fold increase risk of spontaneous abortions. So the workplace exposures can get transferred into a home setting. And this is so important to understand. It's not just you as the worker being exposed, but the extent to which you can carry this exposure home to your family. Another example of exposures that are likely to cause workplace diseases in clinical practice is surgical smoke. Now, it's been a while since I've been in clinical settings where this sort of exposure is practiced, but I'm pretty sure that the practice has not changed much. So from the evidence that we have, surgical smoke consists of a whole range of pollutants that are likely to cause adverse health outcomes. Toxic gases, which include carcinogens, agents that are likely to cause reproductive disorders, are in substantial amounts, in substantial concentrations in these sorts of exposures. The National Institute for Occupational Safety and Health in the US has estimated that over 1.5 million healthcare workers are exposed to this each year. Challenge for us is being able to say that this exposure is likely to result in an adverse outcome. There have been case studies, and there have been some studies which have indicated that doctors are likely to be exposed to higher levels of exposure. However, the ability to translate these sorts of studies into larger epidemiological studies to be able to say conclusively that surgical smoke creates these sorts of outcomes is a major challenge. And once again, I'll speak about why these are challenges in the medical setting. Aerosolized medication is probably in the era of the pandemic being increasingly used. And this is some of the outcomes. Respiratory therapists who are exposed to this form of medication were almost 8 times more likely to be diagnosed with asthma after they've started work. And I've put an insert there of the types of outcomes that are likely to be associated with the use of this medication. I'm not sure to what extent these are used in South Africa, but clearly the outcomes of reproductive effects, kidney toxicity, and respiratory effects are certainly causes for us to be concerned about the impacts that this will have on medical practitioners. So there's a whole range of other diseases that are likely to be associated with workplace exposure. I spoke about noise earlier on, and one wonders how doctors will have noise-related outcomes. But in this study, done amongst orthopedic staff, you see here that consultants doing bone surgery have an increased risk of developing noise-induced hearing loss. In the study, definitely a very small study with 27 subjects, of which 16 were actual medical consultants, 50% of them had documented noise-induced hearing loss because of these exposures. If you look at some of the studies around cancers, in this French study, where they looked at about 1,000 doctors generally, and they compared them to the general population around that teaching hospital, generally cancer risks was not increased except for hematological cancers, almost a fivefold or more than a fivefold statistically significant increase when compared to the local population. So clearly doctors are at increased risk for developing these outcomes when we're able to do these proper epidemiological studies. But as I said, we know what exposures doctors experience, but we've not been able to characterize the risk adequately. Similarly, for the exposures that doctors experience, we've not been able to properly define the exposure outcome relationships. And there's a number of reasons for this. Firstly, doctors are not very good participants in epidemiological studies. So in the 1950s, when Richard Dole described the effects of smoking and lung cancer, this study was done amongst the British doctors. Since then, large epidemiological studies, cohort studies amongst doctors have been probably almost non-existent, particularly to understand workplace exposures and occupational diseases. The other challenge is that doctors work in small or individual practices. Trying to characterize exposure in these settings is extremely difficult. And from an epidemiological point of view, a major challenge. So for all of these reasons, we're not able to properly characterize the risk, and we're not able to properly determine the epidemiological outcome. We're therefore forced to rely on precautionary principles. So having conducted a risk assessment, which we can do in every workplace, and medical practitioners can use a sort of rational approach in understanding the risk and conducting risk assessments. If you determine that you are likely to be exposed to a higher level of a particular pollutant, a particular exposure, then use precautionary principles to protect yourselves. And once again, I refer to the principles and tools that we have in occupational health. So what have we done so far? We determined that in large numbers of clinical practices, there are hazards which need to be controlled. We need to know what are the levels of risk posed by these hazards that we see in these workplaces. Excuse me. The next step is we've discussed the health outcomes associated with these exposures. What I want to do now is to go back a step and look at how we control these hazards. And in the context of COVID-19, this has come to the fore, where we speak about a whole range of controlling of exposures, controlling of hazards, and the use of PPE. So once again, another principle in occupational health. We speak about the hierarchy of controls. What is the best method to control and what is the least effective method of control? And this, thankfully, is stipulated in South African legislation. South African legislation places a considerable amount of emphasis on the hierarchy of controls and advises that as far as possible, we work on eliminating the hazard. And as you can see here, it's the top part of this inverted pyramid. We remove the hazard. If we're not able to do this, then we look at replacing the hazard. For example, latex gloves was seen as being a problem in that it caused vast numbers of healthcare workers to become allergic. We're not able to replace gloves. Gloves are an essential tool in clinical practice. So the step was to look at replacing the hazard with something less hazardous. As a result, now we have latex-free or hypoallergenic gloves. But what we like to do if we're not able to eliminate or substitute is to look at how we can control using engineering means to prevent people from being exposed. But this generally doesn't work. And as we know that when we look at the pandemic, the two most important methods of controlling our exposure was the use of PPE and administrative controls. And as I said to you, the South African legislation, the hazardous chemical agents regulations under the Occupational Safety and Health Act clearly stipulates that this PPE is the last step. You only use PPE when you've shown the other steps are not reasonably practical. But clearly in a clinical setting, we tend to resort to PPE and administrative controls more frequently than we would with elimination, substitution, and engineering. And this is because we're working with people. People bring in the virus to us. There's no way you can eliminate or substitute that unless you start thinking about methods of telemedicine and those means. But the best that we have now is the use of PPE. But let's talk about ventilation, because this also became quite a big issue in the epidemic. We talk about the use of ventilation in clinical practice, and essentially what we're talking about here is how do we control exposures to vapors, gases, aerosols, and particles. And this debate about is the COVID-19, is the SARS-CoV-2 virus a particle or an aerosol? Because this starts to influence how we manage and how we control the virus. The big debate was, is this just a short-range transmission? In other words, do we need to focus just on the non-therapeutic interventions that we've spoken about so extensively, which is use of a mask and social distancing, or is long-range transmission possible? A number of agencies, WHO and the US CDC, have concluded that yes, long-range transmission of the virus is possible, particularly in places where it's enclosed with inadequate ventilation, where you have situations of increased exhalation, for example, people singing in a choir, people coughing, and people sneezing. This would result in a longer spread of the virus particles. And then you have prolonged exposure in various settings. To address this, the Occupational Health and Safety work stream within the National Department of Health, which has been responsible for the issuing of several guidelines over the last year and a half around the virus, has just released its guidelines for ventilation, and this will be circulated to all parties in the next few days. So what is ventilation? Ventilation is defined as the process by which air is intentionally provided to or extracted from an indoor space for the purposes of diluting or removing indoor contaminants. So that's quite key. It's an intention to make sure that we reduce the risk of the indoor contaminants. And as I indicated, these indoor contaminants could be gases, vapors, particles, etc. What must be emphasized that ventilation is not air conditioning. If you have an air conditioner in your clinical practice, that does not automatically mean your practice is well ventilated. Most ventilation systems do not bring in the outdoor air, and unless you're certain that it does, then you need to make sure that your systems are bringing in clean air and diluting the contaminated air that you have indoors. So the question is then, how do we know in the environment that we're working in, that we're sitting in, that we have adequate ventilation? In the absence of doing any objective measurements, it's personal comfort. So you're sitting in a hall of, in a room of 50 people. How well are you feeling? Do you think it's stuffy? Do you think it's getting a little bit too warm? Those could be indicators that your ventilation is not adequate. What we'd like to see that in any environment that your CO2 levels, your carbon dioxide levels, does not go beyond 800 parts per million. And if it does, then you have inadequate ventilation. For healthcare facilities, we speak about air changes per hour. And depending on the type of environment you're working in a healthcare setting, this can range from 6 to 12 air changes per hour. In other words, the entire volume of air in that particular room must be exchanged at least 6 times to 12 times. Certainly in all clinical settings where there is a likelihood of a biohazard, then you want to see at least 12 changes per hour. The pictures, graphics on the right, one is a CO2 monitor and the other is a air change anemometer, which tells you how many air changes you have per hour, and you use these to calculate whether the air changes are adequate in your practice. The WHO has stipulated that for the SARS-CoV-2 virus, you need a minimum of 10 liters per second per person in that room of air for every person in the room. Sorry, 10 liters per second for every person that is in that room. There are 2 types of ventilation that we speak about, natural and mechanical. Clearly, we'd like to emphasize that natural ventilation is the best way because it's the cheapest and most controllable. We want to see, so you have different types of natural ventilation, single side or cross ventilation. Clearly, in most settings, the cross ventilation is the most appropriate. But in other settings, such as your aerosol generating procedure rooms, you want to have much more control over the ventilation. And so you may have the establishment of ante-rooms and double doors to protect yourselves. The WHO has prescribed a roadmap to how we should improve ventilation, but the best approach is, if you're not using natural ventilation and you're not satisfied with this achieving the air exchange that you require, then you need to bring in your experts to start talking to you about mechanical ventilation. If natural ventilation doesn't meet these standards, then we need to look at other options. You could look at, almost as a stopgap measure, is mobile cleaners with what we refer to as high efficiency particulate air filters. These are, once again, even if you're having these, then it has to be done in consultation with the necessary experts. Depending on the type of environment you have, for example, if you're working with chemicals, you're working in an aerosol generating area, then you need to start thinking about what sorts of extraction ventilation you need to install in your environment. And as I said, surgical smoke is a major issue. And if you are working in a setting where you are using these, then we need to speak about local exhaust ventilations and suction units within the breathing zone of the operator. And this is clearly, if if a person is working with these instruments, it's no point in putting a extraction ventilation or window behind the operator, because then the pollutant is the breathing zone of the operator is within the pathway of the pollutant emission and the extraction window or mechanism that you may have in place. Another issue that has come to the fore, particularly during the period of the pandemic, has been that of ultraviolet light. Now, we know that for many years that ultraviolet C band is an established germicide agent, and it has been used in many healthcare settings. However, the CDC in the US, as well as the WHO, at this point in time, is not happy with the level of evidence for SARS-CoV-2 virus itself. Although it's been shown to be effective against other coronaviruses, the evidence for the SARS-CoV-2 virus is just not there yet. And part of the reason is that the challenges in actually using UVC light for controlling of or disinfection of the virus. Firstly, it requires direct exposure, and it requires a specific dose. Now, even though we speak about the C band, the C band it covers a broad wavelength, and commercial lamps, because they want to err on the side of safety, may not meet this particular wavelength that results in a germicidal effect. So getting commercial UVC lamps may not be most appropriate. And there are a wide range of risks associated with this, particularly things like blindness or other eye problems, as well as skin disorders. What has been shown, however, is that this can be used for the upper room air and air handling units as a supplemental measure to control air disinfection. And the image on the right shows this. You need this to be placed at least 2.1 meters above the ground level, with a light shining towards the ceiling and not downwards towards the people that may be in the room. UV lighting is not recommended for surface cleaning. Under controlled conditions, it may be used for PPE disinfection, but once again, it has to be done on the basis of advice from an expert. So it's not a question of using commercially available products. You've got to make sure that this is appropriate for the germicidal range in terms of the wavelength. So finally, I just want to speak very briefly about personal protective equipment. For us in occupational health, we were quite pleased to see the way people approached the pandemic and basically trying to understand principles of occupational health in addressing the control of the hazard and protection of people. But we also saw that because people were not adequately trained in understanding these different approaches, that it led to more problems thereafter. So the first principle about personal protective equipment is that by definition, it protects the user from the environment. So I'll speak about this just now as to why I'm emphasizing this. But also, as I said, in terms of our legislation, and in terms of our understanding, PPE is the least effective and must be the last line in controlling exposure. You've got to be able to show that all other means of controlling exposure has failed, and you therefore resorting to PPE. When you choose PPE, you must have evidence that it reduces exposure. And we saw this. If you take the discussions that we've had around mask usage, do you use a N95 mask? Do you use an N99 mask? Do you use a FFP1, FFP3 mask? So All of these have different levels in which they will reduce exposure to the virus particles. And because of this, we then need to make sure that we're using the appropriate equipment at appropriate time. Other principles are that you've got to make sure that you have the correct selection, the appropriate use and training, cleaning and storage. Now, when we look at how the epidemic unfolded, we saw large numbers of people insisting on the use of PPE, and basically everybody became an expert in the use of PPE. Unfortunately, people were not appropriately trained, and therefore we had challenges with the correct selection and the correct use at different points in time. But these are legal expectations of the employer. Under our hazardous chemical substances, chemical agents regulations, hazardous biological agents regulations, the employer is expected to provide these sorts of equipment if all other means of controlling the hazard has failed. Also, making sure that if you are using PPE, it gets properly disposed of. PPE ought not to be taken home. It ought not to be used in any other settings except in the workplace. And therefore, at the workplace, there's got to be a proper procedure defined as to how these get disposed of. In the context of the epidemic, and I want to emphasize this, as I said, PPE protects the user from the environment. So although a cloth mask is a legal requirement under the Disaster Management Act and the consequent regulations, and a surgical mask is also a stipulated requirement under the directions from the Department of Employment and Labor, both of these are not personal protective equipment. Neither of these two protect the user from the environment. In both instances, these protect the environment from the user. And that distinction has got to be made quite clear in the epidemic, because people often think, well, I'm using a cloth mask or I'm using a surgical mask and therefore I'm protected. This is not the case. In studies that have been done with surgical masks, anything between 20% to 80% of particles may pass through a surgical mask. And that's because it is not a PPE. It is not fit tested, and it is not intended to protect the user from exposures that they may have in the working environment. So finally, in summary, I'd like to emphasize that doctors in clinical practice are exposed to a range of hazards that are likely to result in adverse health outcomes. Doctors' practices vary considerably, and you cannot make assumptions about a sort of one glove fits all approach. You've got to conduct risk assessments to determine whether the exposures that are experienced in your workplace are likely to create problems. If you do, then you need to identify measures to reduce the risk, and where possible, you want to look at engineering controls if this is reasonably practical. And what we tend not to do is we don't monitor the health of workers. So we ask, but yeah, I work with this agent all the time, but I've not had any problems. Possibly you've not, but there may be subclinical effects that you do not pick up until you've long since left that particular working area. Because doctors are likely to have problems, and this is distributed across a wide network, we're not able to do the epidemiological studies to show the definitive increase in risk. But we need to put into place methods to ensure that we're monitoring the health of workers, monitoring the health of doctors based on the exposures that they experience in the workplace. I once again thank the organizers, and I thank you for your participation in this talk. I look forward to having discussions with you after this. Thank you very much.